Is there a way to do that on this platform? I can only see like the speakers, no?
Are you using a computer?
I am. Hey, Monica. Yeah.
Hey, Anna. If you're using a computer, then I think you have to do the gallery view. So
gallery view. So how do I get there? Go to
on your right. You see the
upper
view.
right.
Upper right.
Yeah. If you try that right and it doesn't work, try the other right.
Because my right here says, I mean, I just see the 4 people.
What's up on the?
Well, I can keep scrolling. I have to keep scrolling to everybody.
No. Go to view. Do you see view on your right?
On my right.
I think it's like a waffle.
So you have view, and I think maybe.
Oh, I see view. I see it. Go to gallery. I got it. Thank you, Monica. Thank you. There it is. That's good. That's better. I can see everyone. It's so awkward. There we go.
Yeah.
Right. Hello, everybody.
Good evening.
Good evening.
Who is the host? My video isn't showing. It says the host has stopped it.
Huh?
Oh.
It says you can't start your video because the host has stopped it. So this is Obi.
Yeah, so only the panelists would have access to video for the time of the event. So when we're taking questions, we'll turn it back on. Yeah.
Oh, okay, that's it.
All right.
Gomi, any chance you can allow people when they come in to actually have the video on, and then when we are starting?
Actually, I really think, Gomi, you should just give 5 minutes for everybody to have access. Then you let everybody know.
Yeah.
That's when you start recording.
So, for example, people don't know Ogakunle Oyekon. They pass on for road. They're not going to say.
All right, everybody can unmute and turn on their video. Thank you.
And nobody will know Ogake is out of the country too. So
looking up the sun.
Which country is the correct country now? You don't come.
The United States.
Thank you for that.
You know, okay, I'm for you now. You should know. I'm always with you.
I'm old. I've retired.
I'm going to leave and come back. My Zoom is acting up.
So, Agaladi, good to see you. What part in Maryland are you at?
Silver Spring.
Oh, very nice area. My brother used to live around there.
I'm in Elkridge, Maryland too, so we should, hang out sometime.
Absolutely.
I have a lot of Marylanders here. We party hard, so welcome on board.
Is there anybody in Florence, South Carolina? Like, I feel like I'm the only person for this axis.
Until they impeach Lindsay, then we'll start coming that way.
I totally support. He needs to leave the office. Let the young blood enter there.
Oh boy, they couldn't pay me enough to come down to South Carolina.
I understand. Racist city number 1. Trust me.
I'll take the pay, but I'll work remotely.
All right, I think I'm fine. Yeah. Hello, everybody. Kenneth Iyamu here.
Hello, everyone.
Good
evening.
Well done, my brother. Greetings,
yeah, thank you. Good to see you.
We can start in 4 minutes, Gomi. We'll just give 10 minutes.
Oh, awesome. I still don't know why I'm starting this, but okay. I'm like, y'all couldn't find a clinical person?
That's fine.
That's
I'm clinical. I'm clinical.
You are?
Well, and I appreciate that, because I like little bits of people and dead people.
So they don't talk back.
They don't talk back. Their parts don't talk back.
Cyril, okay, really that's why Kay ran.
Oh, no, he got other issues. I was told he rejects food, so a girl's got to keep it moving. All right, let's be serious now. Where are we?
Or are we starting 3 minutes?
Let me see some faces where I know they see, except when the matter relates to life and death.
When are you coming back?
I said that when you people fix the sun and it's working, then I'll come.
It's working here in Texas.
No, sun is broken there. That's not sun. I know what sun feels like. You cannot have sun and be shivering at the same time. That's -3. That's a broken sun. I grew up in Africa where the sun walks.
Really?
And I see you.
We start in 2 minutes.
Hey, Jide. And
Good evening, Ed. Good evening, Ed. Long time.
Long time. How are you?
Very well. How are you?
I'm good, thank you. Nice
Good to see you. Thank you for joining us today.
Oh, absolutely.
Hey, Judy, how you doing?
Very good. How are you?
I'm good. I'm good.
They say sun don't break for enough place.
Sun deal. No mind.
Monica, now only me you know greet, Abby. We're going to ban the girls. I will continue to support banning the girls.
Mr. Harrison,
It's only me she did not say hi to.
Don't even.
It's only me she's not saying hi to.
Has to be on.
Some of us join this meeting so that we can see the females. Let's be candid. It's not to see the male face. You don't need to see the male faces, so please.
And when I said y'all talk a lot, somebody said no.
We start in 2 minutes. 1.
Yes, go me. I'm on my way over in 1 more minute. Yeah.
Let me quickly go get some.
So people can be serious like this. Sure.
Go, man, you can mute everybody now. Give access to who you need to give access to. You hear me, Gome? You can mute everybody you need to mute now. Give access to who access ought to be for, and let's proceed.
Yeah, you could turn off the videos as well, so only panelists can stay on. Okay. All right, let's get started.
All right, so ladies and gentlemen, welcome to this talk that we have all been looking forward to. My name is Kayode Atobatele. I am the president of the North American Ex-Jam Association, and I am so happy that we have this opportunity actually to have this conversation. So, I mean, if I think I will try and read the qualifications of just the moderator so that you know the caliber of people we've been able to pull together for this. Let me start by introducing, yes, the moderator for tonight. Wow, this is really long. Okay, let me see if I can be fast. Dr. Kingsley Ndoh, right? He's proudly an ex-jam. For those who are joining, because I see some of the people that are invited that just came, ex-jam means ex-junior airmen, all from, and then you also have the ex-junior airwomen, both from the Air Force Military School in Jos and the Air Force Girls Military School in Jos. So that's where most of the panelists are. And then we have a guest panelist actually, who you are going to meet also very soon, an amazing person too. So we are very, very privileged to actually have this combination of brilliant minds who are at the forefront of tackling this COVID and have hands-on experience to, one, talk about their areas of specialty, two, to actually be able to answer the question. So for those who are thinking, like some people have seen some videos where somebody took the vaccine and then they started shaking, you know, these are the people to ask, you know, how many people have they seen like that? Just please bring out all those questions to help, first of all, people listening on this and the people who will replay this recorded session later on, right? So if you know there are some things that people are thinking of, but they are not here to ask on their behalf. This team can answer all the questions. And when they can't answer it, they'll tell you the truth about it. So next, I want to introduce the moderator for tonight. His name is Dr. Kingsley Ndoh. He's a 95. Kingsley, can you wave just so that they can see who I'm talking about? Yeah. Mm-hmm. So Kingsley is a 95 set ex-jam. He's a clinical assistant professor of global health at the University of Washington and an affiliate investigator at the Vaccines and Infectious Diseases division of the federal, is it federal? The Fred Hutchinson Cancer Research Center in Seattle, Washington. His work broadly focuses on the reduction of the inequalities in cancer control in sub-Saharan Africa. Previously, he led the African Access Initiative program in Nigeria at Seattle's BIO Ventures for Global Health to improve access to affordable cancer drugs. He worked closely with the then Minister of Health and Oncology stakeholders to successfully execute a countrywide cancer needs assessment. This led to the submission of proposals from leading pharma companies to the Nigerian government for affordable and sustainable access to prioritized cancer drugs. He resides in Washington State. He's been a leader in responding to the corona pandemic since the first case in the US appeared, and he's going to be sharing his perspectives from an epidemiological standpoint. That's so difficult for me to pronounce. To understand the numbers, projects, and novel therapies that will help stem the tide. He was recently named the Young Leader in Cancer Control by the Union for International Cancer Control in Geneva, Washington, and then Washington State, where he resides. He has shown admirable leadership in responding to the pandemic. So I will stop there because it's still long. And we're just very, very privileged to have him here. Within our small group of brotherhood, we call him our Dr. Fauci, because all things COVID, initially, he was the one educating us. So we're really, really glad to have him moderate tonight. And just so that you understand the gravity of what's going on, and this whole COVID, just today, unfortunately, about a couple of hours ago, I got an email, first actually from Mina, an ex-jaw, telling me that we just lost an ex-jam today to COVID, right? And so let me pull up his name here. His name is ex-jam Rodney Osaji. Did I get that right?
Osaji.
Yes. Osaji, right? Rodney Osaji, we lost him to COVID today. So this is actually, while we're happy to be able to give this presentation and talk about this actually hits home more than you can imagine, right? So this is no longer a drill for us. We've now lost somebody that we know personally to it. So I hope that we will seize this opportunity and just ask all those questions for the sake of the people who will listen later on, so that if the conclusion is to go out and take that vaccine, that they will be completely convinced about it, because we cannot afford to lose the brilliant minds that we're losing to this, especially if there is a solution. All right. So for the one that we lost today, particularly to COVID, I'd like for us to observe, wherever you are right now, 1 minute of silence, and that will start now. May his soul rest in perfect peace. All right, so Kingsley, over to you, and thank you once again for everybody who is here.
Thank you so much, Oga K, for the very kind introduction and
Good afternoon and evening, everyone. Thanks for joining. I have the privilege to introduce the other panelists, and I'll start with Dr. Ronke Akintola. We call her our honorary ex-jaw, and we're very honored to have her here. She's the chief of the Department of Pathology, and she's a board-certified anatomic and clinical pathologist and psychopathologist with subspecialty in transfusion medicine. She has worked broadly on the validation and the implementation of different testing platforms for COVID. And so it's really an honor to have her here to share those thoughts and answer questions. In her spare time, she loves reading and cooking. And so, Ronke, maybe you could wave so that people would see you.
Good afternoon, everybody. Thank you all for the invitation. It's a pleasure to be here.
Thank you. And the next panelist is all the way in Florida, where there's a lot of alligators and big snakes. That's what we know about Florida. So I hope you're staying safe from those. But anyways, Dr. Kenneth Iyamu, he's a very senior ex-jam, 81 set, Purple Squadron. He's an assistant professor of internal medicine, and he's the internal medicine residency program director at Central College, Florida College of Medicine. And then I think Dr. Ken, you should wave to the audience so they see you. Yeah, thanks for being here.
Yeah, good evening, everybody. Thank you. Nice to be here. Thank you.
And then we have Dr. Cyril Ikechi. He's 94 set, Green Squadron. He was in my squadron. I know we used to fear him those days. It's nice to see him. All right, anyways, but it's nice to see Dr. Cyril here. He's the assistant director of hospital quality management and regulatory affairs. Actually, Dr. Cyril is based in New York, where we had the epicenter of COVID-19 here in the US. And he'll be sharing a lot of his thoughts. He's in the Lincoln Medical and Mental Health Center in Bronx, New York. So, Dr. Cyril.
Good afternoon, everyone, and thank you for inviting me.
Yeah, and then we have an ex-jaw, Dr. Ojile. She's a board-certified physical medicine and rehabilitation medicine. She obtained her BSc in biological sciences from City University of New York in Staten Island. And she went to medical school at Temple University School of Medicine in Philadelphia, where she got her MD degree, completed her residency in physical and rehabilitation medicine at Temple University. She currently practices in South Side of Atlanta, and I think she'd really be bringing a lot of that expertise to bear in these discussions. She has been in the front line with COVID-19 patients, seeing patients in the ICU, and I think she's going to be bringing a lot of that expertise and clinical experience to this talk. So I'll say, Dr. Ene, please wave so that the crowd, the e-crowd can see you. Yeah.
A quick correction, not in the ICU, after they leave the ICU and then they come to the rehab hospital, that's where I see them. So after
okay, I'm sorry, I was skimming through, but yeah, sorry,
okay.
Thanks for the correction.
Right. Hello, everyone.
Okay, so and I'd like to mention that Dr. Ene is an accomplished singer and songwriter and musician. That is amazing. Okay, and then we have my very good friend and senior brother, Dr. Iliya Amaza. He's a pulmonologist and critical care medicine physician. He's a clinical faculty at the University of Madison in Wisconsin. And we all know that the primary place that COVID-19 affects is the lungs. So we're very happy to have him here. And then we have another good friend, senior brother, Ladia Kimboro, Dr. Ladia Kimboro. He's an oncologist, and he's with the lung cancer team in the FDA. and he's going to be bringing that whole approval expertise, because a lot of us have questions on, oh, why did COVID-19 vaccine just get approved like in 9 months? Can we trust it? And so I think Ladi will bring in that experience he has had in the FDA to this discussion. So we're very happy to have all of you, and I know it's going to be a fun event and a very educational event as well. And again, may Rodney Osaji's soul rest in peace. I think this discussion is really coming timely, and we're very happy for everyone that has joined the call. Okay, so I think without further ado, Dr. Ronke is going to be presenting sort of a landscape overview of where we are with the COVID-19 pandemic and where we are with vaccines. And so, yeah, so she'll be sharing her slides. Okay, so I think the co-host will share her slides. Let me see if I can share it from my computer. 1 second.
Thank you.
Let me share this from my computer. Okay, just give me 1 second. Let me navigate. Okay, can everyone see the slide?
Not yet.
Not yet. Okay, 1 second. 1 second. I'll get it up. Great. Okay.
All right. Perfect.
So
if we could go to the slide view. Thank you. Good evening, everyone. And again, thank you for this opportunity. I do think that it is very timely. So I know everyone has heard that COVID was first talked about in Wuhan in December of 2019. It started as an unknown disease presented as a pneumonia, which is an infection of the lungs, and people got very sick very quickly, and many of these people died. As is customary with unknown viruses, of which this is not the first coronavirus or first unknown virus to appear, there is a lot of work that goes into determining where the virus came from, what are the signs and symptoms, and how to identify them. In this particular case, it was noticed that older people who have underlying conditions like cardiovascular, lung diseases like asthma, or diseases like diabetes seem to do much worse from this virus. The other thing that was quickly identified was that this disease affected minority communities in places like the United States. So it disproportionately affected African Americans and Hispanics. Next slide.
Okay, 1 second. Oops.
So when this first presented, it was noted that people developed symptoms anywhere from 2 days to 2 weeks after exposure. And it presented like a fever, a respiratory tract infection like the flu, but you could also have body aches. So if we translate that to our home country of Nigeria, people might think, well, I have malaria. I have a cold. But the other things that were noticed was that people would lose their sense of taste and smell, and they would have nausea or vomiting and diarrhea. So this was really a multi-systemic presentation, and not everybody had the same symptoms. Next slide.
Oh, sorry, 1 second.
As we studied this a little more, it was noted that some people would be doing fine and all of a sudden would have marked trouble in breathing. They would have chest pain. They would appear confused. And these are the kind of symptoms that, as we learned about the disease, if you had those symptoms after being ill, it was suggested that you go to the hospital and get an evaluation. Next slide. So this is a slide that really just shows you how global this disease is. So it's been reported in many countries of the world. Some countries handled the pandemic better than others. As you can see, the map in Australia is really limited to the coast. But as of this week, there have been over 105 million cases that have been diagnosed of COVID-19, and there have been 2.3 million deaths. So while you might live in a country that does not keep records or does not appear to be affected, it really has had a devastating impact on many communities. In the United States, at this point, we are over 26 million cases and over 460,000 deaths. Next slide. Thank you. I had mentioned earlier about the disparities in by ethnic group. And so here in the United States, the CDC has a daily tracker that looks at all of the deaths with the information that they have. And so this information was available in about half the cases, but you can see that the percentage of cases, while higher in white and non-Hispanic, and we can go to the next slide, there were a large number of cases in Black and Hispanic people, but the percentage of deaths were also fairly high in Black and Hispanics. In the United States, Black people are approximately 13% of the population, and they've had about 15% of the deaths. When you look at the age groups affected, really it is adults who are disproportionately affected. Children seem to present as asymptomatic carriers and do not have the bad outcomes that adults have. Next slide. All right. And so when you look at the cases by sex, females presented with more cases, but somehow females tend to survive more than males. Take that as you will. I'm sure that the statistics are probably equal among the ex-jaw and ex-jam. But so we'll go ahead and talk about diagnosis. This is a virus. If we could go back. Thank you. There are various platforms for making the diagnosis of COVID-19. The gold standard is PCR. So for those who have been traveling in the last 6 months or so, most countries are requiring a negative PCR before you can enter their country. But there are also antigen and antibody tests. When you look at these tests, the sensitivity and specificity of each platform is different, which is why they need to be validated where you're taking your test. And the information provided by these tests also requires interpretation by your physician. Next slide. So having given that overview of the number of cases, the morbidity and mortality, I think everybody really wants to know about the vaccine. Currently in the United States, we have the Pfizer and Moderna vaccines. They both require 2 doses, 21 and 28 days apart, and they have about 95% efficacy. AstraZeneca, Johnson & Johnson have an adenovirus-based vaccine. And I'd like to just note that Johnson & Johnson had a previously approved vaccine for Ebola and Zika based on the same methodology. Johnson & Johnson just yesterday applied for authorization in the United States so that their vaccine can be administered. And it only requires 1 dose. It also does not need to have the storage that the Pfizer and Moderna vaccines do, which for countries that don't have continuous electricity supply would be difficult. So next slide. All right. So I know that there were several questions before this asking about post-vaccination side effects. They are very similar to any other vaccine that you might have received as a child or as a young adult. You can get some tenderness at the site of the injection, some body aches, fevers, tiredness. This usually resolves in 12 to 36 hours. I'm aware that multiple people on the panel, including myself, have already received the vaccine. And there is no truth in the statement that you will grow extra body parts, or it leaves a mark, or there's a microchip. So next slide. Okay. So currently, as of this past week, 140 million doses have been given in about 66 countries. In the United States, where about 34 million have received one dose. And so we're talking about 8% of the United States population. So there's a lot of work to be done. Less than 2% have received 2 doses. There have been issues, as I'm sure many who follow the news here know, of distribution troubles and so on. When you look at a country like Israel, they have a very high vaccination rate of over 70% at this point, and they seem to have a very good handle on how these things should be done. So I'm sure there's going to be more work into that particular case study. Next slide. So to answer the questions that many have asked over the last year, the first one, that the vaccines were developed too fast. There was a lot of global collaboration into the development of the vaccines. Many of these platforms, including the mRNA platform that the Pfizer and Moderna vaccines are based on, are really not new technology. They've been in existence for over 15 years. And it was the fact that people were able to come together. There was a lot of money involved, put in by governments, that allowed the work of on these vaccines to move forward as supposedly fast as they did. Can we go back to the last slide, please? There's also this question of mRNA changing your DNA. mRNA is a messenger. There is no way it can change your DNA, or that the vaccines have dangerous ingredients. And really, this ingredient has the mRNA, a fatty layer so that it's protected while it's stimulating your immune system, and just salt, sugar, and water. At this point, millions have been vaccinated. There have been no known reported deaths associated with the vaccine. There have been deaths in some people in close proximity to the vaccine, but they had underlying conditions at that time. So there have been no deaths as of today that are directly associated to the vaccine. And at this point, I will turn it back over to the moderator for any additional questions. Thank you.
Thank you so much, Ronke, for that excellent presentation. Thank you so much. Yeah, so I think that was essentially a landscape overview. And a lot of you had questions that you had sent beforehand. And I think that's why we have this excellent group of panelists to help us to answer these questions. And, you know, the first question, I would direct the first question to Dr. Amaza, and then other panelists can chip in. Some people wonder how long the immunity for the COVID-19 vaccine would last. And would it be like flu shots every year, like you get you know, your flu vaccine every year? Like how long is that immunity expected to last?
Yeah, so that's an excellent question. So this is these are new vaccines we're dealing with. The trials were done just starting last summer, so we will need time to know how long they will last for. But based on like the phase 1 trials of one of the vaccines, the Moderna vaccine, we know that those who got those doses, it was a small study, but we know that 4 months down the road, they still had adequate amounts of antibodies. So we'll have to see how long this will go on for. There is hope that it might be, it might be a yearly thing every few years. or something in between. But we'll have to see. We'll have to wait and see how it plays out. One of the ways will be through vaccine surveillance. So if a time comes when we begin to see cases of new cases of COVID after adequate vaccination, after completing the vaccination series, then that will give us an idea of how long the immunity will last for. But for now, the simple answer is we don't know.
Yeah, and that's true. This vaccine is all about science, right? You cannot predict the future that you've not seen. So you have to sort of observe those that you've given the vaccine and, monitor them. One question that people really have in their minds, and I have here that was pre-submitted, is a lot of people are doubting the vaccine. They were approved so fast, 9 months, it's crazy. No one has seen that kind of speed before in the world of vaccinology. And, people are just wondering, like, did they just cook up something and then they just approved something? Dr. Ladi works, he's with the FDA, and the FDA or any regulatory body in any country, they have the role of approving, drugs, medical devices, vaccines, and their number one priority is to make sure that whatever is being approved is efficacious, is effective, and is safe. And so maybe Ladi, could you shed more light on this, on why, why you think this just went so fast, and should we trust it based on this speed?
Yeah, good evening, everyone. And, I'm glad to be here just to take a shot at that question. So I'll just say thank you again to Dr. Olaronke for that, for that presentation. And, one thing she pointed out was that, the mRNA technology that were used, at least for the vaccines that have been approved in the US, are not new. So we've had this around, and these very pathogenic coronaviruses that cause COVID, they're not exactly new. In the 2000s, we had the SARS-CoV-1 that really emerged in Southeast Asia, and in the early 2011, 2012, there was the MERS-CoV in the Middle East. These are similar, and at that time, there were also actually some vaccine, there were some vaccine efforts that had started, but they got stalled because those epidemics got, controlled. So there's already been some work that's already been started with regards to this coronavirus, to coronaviruses in general. So coming to COVID, yeah, it's a different strain of SARS-CoV, but it's not exactly new. So already, we were just building on some of the work that's been done before. And then again, we are lucky in 2020. This is 2021 and not 1920. So we can easily integrate data that we have from all over the world. They sequenced the coronavirus DNA, the sequence, the RNA was sequenced, way back last January, so that we knew exactly, what the virus was. And so the pharma companies, started building on that, just taking pieces of that virus, knowing what proteins they code for, and developing the vaccine based on that. So that's all about the science. Now, before the FDA even started reviewing all this data, we must give, as much as I know, the politics around the last transition has colored, the eyes with which people see the last administration. You must give the president kudos for the National Emergency Authorization Act that he invoked. And one of the positives to that was the Defense Production Act, which really gave companies, or rather gave the government leverage to ask companies to direct all their energies towards producing these vaccines. So that really helps with the logistics, because normally it takes companies several months or years to just figure that out. But within a few weeks, because the government harnessed all its efforts towards production of these vaccines, that really helps, with the production. And then coming to the review, to the trials that were conducted and the actual review. Now, normally for production of drugs in general, and then vaccines specifically, there are different phases of trials. From the preclinical phases where you test them in animals, and then to the clinical phases, and there are 3 main phases of trials. Normally, these run sequentially. You finish one before you start the other, And each of them, they take several months to years to run. So as you can imagine, that means that developing, for example, the measles vaccine way back in the, I don't know, was it 1950s or 60s, and have taken 5-10 years. But because of all the information that we already had, we didn't need to do that. And of course, this was emergency. So some of these trials actually ran concurrently. So the phase 1 trial, we didn't exactly need to finish all of that before we went on to phase 2. And we didn't need to finish all the phase 2 before we went on to phase 3. We could leverage the data that we had, from just some of the preliminary data to go on to the next phase of trials. So that's that. And then the one thing I just want to emphasize, I've not been at the FDA for too long, but one thing that, that really struck me the 1 year or so that I've been here is just the emphasis on safety. In fact, more than efficacy, that anything that the FDA approves, must be safe. And for any new product that is good, that is going to be used in humans, you must be assured, that it has been thoroughly tested in animals. They give them, rats, dogs, monkeys, you kill them. We see what do they do in your heart, in the brain. So we thoroughly know, at least, before you give them to humans, we have a fairly good understanding of what are the likely effects of these drugs and the vaccines too. And then, reviewing all the data too, the FDA doesn't turn any, we don't leave any pages unturned, mostly because these vaccines are going to, the majority of people who will be getting them are healthy. So you don't want healthy people to come down with sicknesses. My own area, which is really cancer, even with patients who have advanced cancer, we still emphasize safety. Talk more people, who are healthy. Many people, you have mothers who are pregnant, who are lactating. You don't want those people to come down, with complications, down the road. So there's been the emphasis on safety at the FDA cannot be understated. So I just want, I don't know what reservations people may have, but be confident that anything the FDA authorizes, safety, we don't compromise, on safety.
Well, thank you so much, Ladi, for that comprehensive answer. I think we have a lot of questions coming in. One of the key things that he has said is safety is something that is non-negotiable when an approval committee is sitting down to approve a vaccine or a drug or whatever they're approving. Safety is number one, much more than efficacy. But before I go through there are just a lot of questions coming in. I think I want us to go back to the basics because I know that a lot of people will have that question. The thing is, what is a vaccine? How does it even work, right? And I'll just sort of make it in a very, sort of ABC format, right? So anytime a virus infects someone, your body mounts up an immune response to it. And when the real virus comes, and if your immune system haven't seen that virus before, it might overwhelm that person. So what vaccines do is the companies or the scientists will figure out those portions of the virus that makes the body elicit that immune response. And then they can sort of manufacture that part of the virus to impute in their vaccine formulation, so that when the immune system gets exposed to that protein from the virus, it can mount an immune response and create a memory for that portion of the virus that is pathogenic. And so that when the real thing comes, you can mount an even better and more responsive immune attack on the virus. So sort of you're exposing to a weaker part of the virus, and then when the real virus comes, your immune system remembers and then mounts a much stronger immune response. Another thing I know a lot of people will be sort of asking is efficacy, because that's a word that you hear a lot. It's 95% efficacious. So efficacy just means effectiveness. So if we say something like Pfizer vaccine is 95% efficacious, it just means that if 100 people get the Pfizer vaccine and they're exposed to the COVID-19 virus or the SARS-CoV-2, only about 5 of them, the probability is that only 5% of them will get the virus. So it offers sort of 95% protection. So haven't done that basics. And I know there are lots of questions coming into the chat, but I want to kind of go through as much questions that have come in before the seminar, before I go to the chat room and look at the questions that are there. So the question is, can you mix the vaccines if a first shot and second shot are from different sources? Are there implications to this? Is this something that is already being explored? And I know that Dr. Ronke shared an article this morning to the panelists, and we were kind of talking about it. And I'd just like her to shed some light on vaccine. So basically what this person is asking, maybe in your first shot to get like a Moderna vaccine and then second shot to get like a Pfizer vaccine. Is it something being considered?
So I will say that there's currently a study in the UK that is looking at exactly that. And the reason for this, because I'm sure most are aware, if you get your first dose of any multi-dose vaccine, it's normal to have it from the same vendor. In this case, there have been well-documented distribution problems and supplies. And so in order to combat that, there is a study right now that is looking on whether or not you can give both, you get the first shot is Pfizer, the second is Moderna. They are both similar vaccines on the same mRNA technology. So the thought process is that there would not be a problem with that. Same with the other vaccines that are both adenovirus based. But clearly the study has to be done. I will say that at this point, even just getting one dose is somewhat protective. And the goal is to develop herd immunity. So as the more people we can get to have some level of protection, the better for the community as a whole. And hopefully the sooner things can get back to our baseline of normal. Thank you for the question.
Yeah, thanks. So the next question is, and I'll be directing this question to Dr. Cyril Ikechi. What percentage of the nation needs to be vaccinated to achieve herd immunity? And how do we get there with the reluctance and prejudice that we're seeing with vaccination? And, one of the major reasons I'm asking you is because, you're located in a place where we really saw, COVID-19 raging in the US, and we have the highest number of deaths in that region. So, so what's even herd immunity? Like, where do we need to get to know that we're making some form of progress? You're muted.
So, I know in the initial stage of the COVID back in the summer, New York City was the epicenter of the virus, and so for us to get to herd immunity, we don't know how many people needs to be vaccinated, what percentage needs to be vaccinated. We can't give a number off the back of how many people needs to be vaccinated, but we need to at least have at least 80% of people needs to be vaccinated for us to get to herd immunity. Vaccinating everyone should be the goal, because if we get vaccinated, let's say for example, if we have, I know Dr. Ronke gave the numbers of the disease worldwide, which is about 2 million plus. So if we have that 2 million, let's give a round number, 2 million population that have died from the virus, and we don't get vaccinated for us to achieve that herd immunity, then we need to have, let's say 80% of the population need to vaccinate for us to achieve that herd immunity. If we're looking at 20% of the population dying from not getting the vaccine, for us to achieve that 80% of population, we need to at least four times that number. So the percentage of people that actually needs to get vaccinated at this point in time, we don't have that figure at hand. We are hoping that everyone gets vaccinated, or at least 80 to 85%, 90% of the population get vaccinated. From the Department of Health data as of this morning, if you guys observe, there have been a reduction in the disease because New York have actually ramped up their vaccine processes, and we're actually we're opening more sites for people to get vaccinated, not just the 65 years and above, but if you have comorbidities, like if you're obese, hypertension, diabetes, or high cholesterol levels, we're actually having those people get the vaccine as soon as possible, so that way we can reduce the amount of death. So just to answer your question regarding the percentage, at this point we don't have any figure at hand. Our main goal is to make sure that everyone gets vaccinated so we can achieve the herd immunity.
Thank you. And right now, according to what Dr. Ronke shared, just 8% of the US population have received the first dose of the vaccine. There is one interesting question I'm seeing in the chat, and I think I'll just read that out, and we can address that. So Moderna, which is one of the major pharma companies that whose vaccine is approved, Oga Max Ebong is asking, they've not had any successful product to date, and the vaccine will be their first product in more than 3 years. And how do we, based on the fact that they don't have any track record on any product that they've produced and approved, how do we, sort of accept their vaccine since that track record isn't there? I guess that's what the question is referring to. So I'll just read verbatim. Should we be concerned about accepting it instead of other producers? So I'll address this question partially, and then I'll pass the mic to Dr. Iyamu to talk about this a bit. So Moderna has been working on this mRNA platform, which is a relatively new platform for vaccine development. And it's more like preparation meets opportunity, right? So they've been working on this platform. They've been working on machine learning algorithms to be able to better predict what kind of proteins would mount the best immune response. And so when the COVID-19 pandemic hit and the genetic material, the genetic information was published by the Chinese, it was very easy for them to hop on that technology and get a candidate that they were going to manufacture. And that candidate was gotten in 48 hours. That's the speed that they had come up with a candidate based on the technology that they had built over the years. So even though they haven't had any approved products, they have been working on this novel technology for quite a while. And it was more like a situation where opportunity or preparation met opportunity. I would pass the mic to Dr. Iyamu to give further comments on this. Why should we trust the Moderna vaccine, even though they haven't had any track record?
Yeah, thank you so much for this question. And I do want to thank Dr. Ronke and my other colleagues who have given poignant answers to these questions. The question as to if Moderna's vaccine should be trusted, I think that's a great question. To my knowledge, the mRNA technology, the COVID vaccine seems to be the first vaccine that's been produced based on this RNA technology. Again, with what my previous colleague did say, need to go through all the protocols that are needed in developing vaccines, from the preclinical to the clinical 1, 2, and 3 stages, and haven't met the guidelines by the FDA. And as a matter of fact, the threshold the FDA set for efficacy of these vaccines really is 50%. So I mean, prior to Pfizer and Moderna coming up with their vaccines and indicating that their vaccines were above 90% efficacious, I think it really blew everybody off their seats. If you talk about efficacy, Pfizer, Moderna being about over 90%. If you compare this with the with the influenza vaccination, in a very good year, the efficacy of the influenza vaccinations are about 45 to about 50%, you know. So it's kind of just using that as a comparison to vaccines that have reported over 90% efficacy. Obviously, it's time that is really going to tell, you know, because as we all know, we are all still learning new information regarding the COVID infection, you know. One thing that probably may also have contributed to this question as to doubting the efficacy or having trust in these vaccinations, really, I think the unprecedented political environment that really surrounded the vaccine developments last year, there's no doubt it did really play a role in making people have doubts as to if these vaccines are really reliable or should be really trusted. You know, the program under which these vaccines were developed, they called it the Operation Warp Speed, you know. And I listened to someone talking on the television the other day. It says, for people who watch Star Trek, you know, this kind of like a Star Trek designation, you know. So using a kind of like a Star Trek designation saying Operation Warp Speed, you know, it kind of really brings the question as to, is this just kind of like science fiction or thereabout, you know? But as my previous colleague who works in the FDA said, even though these vaccines were developed within in about 9 months in record speed, there were no corners that were caught in terms of ensuring, one, the safety of these vaccinations, and two, as to ensuring that they did go above the threshold that was set for them, 50% by the FDA. If I may just make one or two other comments, you know, I know there was also the question as to whether there are some chips, you know, chips that are injected into people with this. Now, I think maybe where they kind of have this issue about it is the mRNA is really enveloped in what they call a kind of like a nanolipid capsule. If you inject the mRNA into the human body, it's not stable, it's quickly degraded. So these vaccines are really encapsulated in nanolipids or nano fat particles inject into the body. And these fat particles, they help to protect this mRNA until it goes into the cytoplasm of the cell. True, yeah, it does not go into the nucleus. Anything that has to do with DNA or anything that enters into the nucleus, fine. The question as to whether there's alteration in the genetic makeup is there. But the mRNA technology shows that it never really gets into the nucleus. It stays in the cytoplasm, and at the end of the day, once you have the proteins that are transcribed, the spike proteins that are transcribed, they now get exposed to the cells that help the human body to fight infection. And at the end of the day, you end up producing antibodies to the spike proteins. These are the proteins with which the coronavirus enters into the cell. So I think, coming back to your question, I think we have every reason, you know, to really have confidence in the vaccines that Pfizer and, of course, with the question Moderna has produced. I mean, if you ask yourself, what's really the alternative? You know, I mean, we know we cannot testify to the fact that millions of people have succumbed to the virus. Personally, as a health worker, I mean, it was really, as a healthcare worker, it really was no question for me, because if on a daily basis, you know, you see coronavirus patients while other people will run away, you know, we have to go very close to them and see the best we can do in terms of caring for them, you know. So whatever the minimal side effects are, you know, to this vaccination, I felt these are things that I certainly can live with, as to compared to the alternative. I do hope this kind of shed some light into the question that has been asked. Thank you.
Yeah, no, thank you very much, Dr. Iyamu, for that.
Can I add?
Yeah.
Can I add something to that? So just to add to what Dr. Iyamu said regarding the efficacy of the Moderna vaccine. So both the Moderna vaccine and the Pfizer vaccine have the same target, which is the spike protein that produce the signs and symptoms that we have, or that one gets when they get COVID-19. So the vaccine actually being targeted to that spike protein. So what happened is both the Moderna and the Pfizer vaccine, once you get those vaccine, what it does is it activates antibodies against that spike protein, or the S protein, like as it's called, for you to develop immunity against the virus whenever you get it again. So just to add into what Dr. Iyamu said, to answer Mark's question. So basically that's why they have the same efficacy of 95%, both of them, because they have the same target as a vaccine. Thank you.
Yeah, thank you, Dr. Cyril. I'll go to Dr. Ene, and there's an interesting question. I'll still go back to the pre-submitted questions, but there's an interesting question that was sent by Kingsley, and so the question is, did Blacks who died because they are Blacks, or let me just rephrase that question again. So the Blacks that died, did they die because they are Blacks, or did they die because they didn't have access to healthcare? And, Dr. Ene, one of the major reasons I'm asking you beyond your expertise is just the fact that, Atlanta has a lot of Blacks, it's like 60%. So I'm sure you'd have more insights to this, based on your experience. So what do you think? Why do you think Blacks are dying more, even when they're getting the virus less compared to whites?
Absolutely. And again, there are different studies, but if you look at socioeconomic status, right? A higher percentage of Black people are in the lower socioeconomic status range. So what happens typically with anyone, whether they were white or Black, if you're lower socioeconomic status, what happens is that you, typically funds are not available. There isn't insurance to have quick access to healthcare, because one of the things with coronavirus is that, catching it early in a person who is going to develop to severe disease is very important. But if someone does not have insurance, they don't have transportation, or they're more concerned about feeding their families than going to see a physician, and they're likely to not want to see a physician, likely to want to call their uncle and say, you know what was that recipe again with the ginger and the lemon? Let me try that. And unfortunately, by the time things are kind of at a severe level, they're in the hospital, and with the coronavirus, you kind of want to catch things on time before it gets to the point where your respiratory system is fully compromised. So I would say that it is more tied to just the fact that Black people in general have a high percentage in the lower socioeconomic status range versus our Caucasian counterparts. And this is probably also why Hispanics too had a higher level for the same reasons. Thank you for that question, and anyone can chip in if anyone has any other things to.
I would agree with that. I work in a 13 system hospital, and we saw very clear disparities in the hospitals that were predominantly Black, as opposed to the hospitals that predominantly serve Caucasians in the suburbs. So while the Black hospitals were full at the very beginning of the pandemic, the predominantly Caucasian hospitals did not see a surge until the second wave last fall. And it is very unfortunate, because when people cannot afford to take time off work, they do not have childcare, they have to go to work, and for the most part, they have people facing jobs. Mm-hmm. So your risk of exposure is higher because you're exposed to more people come in. And at the beginning, there was not enough personal protective equipment. So people wore all kinds of things or no mask at all. And that was also politicized. And so unfortunately, these people, we're talking of our food service workers, bus drivers, etc., they had no options. And so they came in very late because, again, they also had no insurance and the outcomes were very poor. I was talking to Kingsley the other day and I said, for our system, we had 2 refrigerated trucks to hold the bodies. Each could hold 70 bodies because our morgues were full, the funeral homes were full. And I think for most of us on this panel, this is why getting the vaccine was really not an issue. I was in daily COVID calls and more than 25% of our census was COVID, and we were seeing deaths in the tens, and we're talking, 30, 40 people dying in a 250 bed, 300 bed hospital. So when you see that kind of thing, and you know that there's a refrigerated truck to hold bodies, 20 miles away for your entire system, you tend to look at these things and get the help anywhere you can. So thank you.
So if I may just add to this, and certainly I do agree with the previous speakers also. I think, certainly accessibility, affordability to healthcare, and trust in the healthcare system. I mean, there's a lot of distrust in terms of the care that patients get in the hospital. I think this really might tie into even the issue of that's what we call the vaccine hesitancy. There was a study that I published in Annals of Internal Medicine 2020. Fisher and the colleagues found that some factors were they found some factors that were linked to hesitancy to receiving the COVID and vaccinations, amongst which one was Black race. Is a Black race to young people who are under the age of 60. It also, as part of the factors, it says female sex and less than the college education. I think the issue of less than the college education really has to do with, how much are you able to go out there, process the information that is given to you? How are you able to kind of understand, whatever information that is out there? So in situations in which you have people being hesitant to receiving like vaccinations, which is certainly common in the Black population and of course the Hispanics, they advise that providers should acknowledge to such persons that they do kind of understand, or one is like see how you can have like a conversation with such people. Try have them explain to you as to what are their main reasons, for the hesitancy against receiving vaccinations, acknowledging the fact that this really meets, and try to see how you can recommend like trusted or influential people in their communities, like the Black population. Like going to in the barber shops, people like men, when they go to the barber shop, that is where the local news is being discussed, So if you really come to a situation whereby you go to places where people attend, or the Black community, Black churches and so on, you're able to educate people in that regards, it goes a long way, in kind of reducing their hesitancy to receiving these vaccinations. And there's no doubt comorbidities. People who already have comorbidities, hypertension, diabetes, and so on, they certainly do badly, That's kind of just to chip that in.
Yeah, no, thank you so much. This is, from what Dr. Olaronke said, it's just a stark reminder, just the bodies, it's really sad. And each person that have died, they have family, they have friends. And so, this is a very serious talk, as you all know. But on a lighter note, I'm going to ask a question. This is a legit question that was submitted, so don't laugh. And we have to address it here. So this person is asking, will I grow horns if I take the vaccine? And I would have Dr. Ronke take this because I think it's we talked about it a little bit. So yeah, she would.
So there have been many questions. Thank you for that question and for throwing me under that very well delivered bus. There have been many questions with regards to whether people will develop extra body parts, whether this will lead to a new one world order, like the mark of the beast. With regards to the mark of the beast, I would like to remind everybody that that really shows up in the forehead and the right hand and not in your deltoid or shoulder. So I think you're okay with that. With regards to growing horns, I would like to remind the ex-jam on this call that Pfizer is also the developer of Viagra. So I doubt very much that you'll develop another horn, but maybe, you know, it'll keep other things moving. COVID causes blood clots. I don't think you want blood clots in your essential equipment. That's all I have to say about that. Thanks.
Yeah, thank you. Thank you for that. Okay, so we've all heard that there are now different variants, different mutations that are going on with the original SARS-CoV-2 virus. And, you know, people are wondering, the current vaccines that are approved, are they going to cover for those new strains? And I would be posing this question to Dr. Amaza. I don't know if Dr. Amaza is still, okay. Yeah.
Yes, I am. Yeah, so that's a great question. And it's, even for me personally, it's been a source of concern. So viruses mutate. That's a well-known fact. So take any virus, HIV, influenza, they mutate. And that's why we get an annual flu vaccine, because from year to year, the virus changes its signature. So you have to target a vaccine towards it. So for the coronavirus, it's not unexpected that we have variants coming out. The variants of concern have been the ones from the UK, from Brazil, from South Africa, but there are variants everywhere. There's a Nigerian variant that was announced, I think, a few weeks ago too. So, but the ones that make the news are those three. What we know currently, for some of the, at least for the vaccines that have been approved, both in the United States and in Europe, most of the commonly available vaccines work quite well for the UK variants. For the South African variant, so like Kingsley mentioned earlier, the way you define a vaccine effectiveness is, you know, if you give a vaccine to 100 people, how many get the virus or not. So with the South African variant, for instance, you know, the numbers that have been thrown out by various manufacturers is somewhere in the 50% range. So Novavax just released this data, I think 10 days ago, or around that time frame, and they announced about the 52% effectiveness for the South African variant. That said, it's some protection is still better than none. So it, and I know Moderna has announced that they're going to sort of retool their vaccine or come up with a booster shot that will address these variants. Pfizer said, you know, it will take 6 weeks for them to come up with a new like a booster shot. So, but while all of that is in the works, it's still vital that we know we all get vaccinated, because one, it helps us to achieve herd immunity faster. And if you have some protection and everyone has some protection, then the virus will have very little room to, you know, to disseminate or to spread. And as time goes on, we'll have a better understanding of the variants versus the vaccines. And there have been various predictions of how this will play out. So one of them is that it will just be like the regular flu. You know, it will be reduced from a severe, potentially life-threatening illness to just a nuisance, which is what we are dealing with flu right now. So it's more of a nuisance than a life-threatening illness. Because for one, we know that the vaccines prevent 100% of severe illness. So even in the 5% who will get the coronavirus, there has been no deaths reported in the trials among those who got the vaccine. And there was no severe COVID illness, which you define as people being on oxygen, being hospitalized, and there's certain other parameters. So, so in short, take the vaccine, variants or not, and as time goes on, we'll sort these things out better.
And I just want to add on to that with regards to testing. So questions did come up as to whether the current testing platforms will pick up the variants. And the FDA has assured us that most of the variants will be picked up by the current test platforms. I believe there are only 3 that are of concern. And I would say that for my system, we have more than 6 different platforms that we're using at this time. And all of them have been revalidated to make sure that they pick up the variants. Because again, that's what you want to be able to pick up the disease within your communities. So just to add to that.
Thank you.
If I may just piggyback on what Iliya said too. So I think just to put things in context, even with this, with these new variants, the efficacy of the vaccines is still estimated to be way above 50%, as high as 60%. Put that side, side by side with the flu. Even in the best of years, with the flu, we don't get it that good. So, when you just compare these, and I think it's still, even with the new variants, it's still a win-win, getting the vaccine.
Yeah, so the thing, one of the major discussions right now is sort of vaccine distribution equity, right? And we all have family, friends, and also friends on this call who are back home in Nigeria. And our discussion has been a little bit more US-centric since we started this panel. And I want to just kind of turn our attention a bit to homeland. And the Pfizer vaccine and the Moderna vaccine needs extremely low temperatures to remain viable. And that's because the mRNA platform, mRNA and the nanoparticle that is like a ball of fat that holds the mRNA is very temperature sensitive. So it's it's not that practical for vaccine distribution and that vaccine to remain viable in a place like Nigeria. So what do you guys think? And I'll just throw it to the panel, and anyone that wants to jump in should jump in on this. What do you think would be a viable option for Nigeria and other low to middle income countries that lack the infrastructure to keep these vaccines viable? Pfizer, for example, has spent over $2 billion in the US on just freezer farms. And lots of countries do not have that kind of resource to do it. So what are your thoughts? And I know a lot of people on this call want to know what is the hope for vaccines in Nigeria. And I'd like to add, there are other vaccines besides Pfizer and Moderna, but that's what everyone have been discussing about, right? So hopefully we have other alternatives to pose that question to the panel.
I'll see if I can say something. Yes, the Pfizer negative 94 degrees to store the Pfizer vaccine, and Moderna is a little bit warmer, negative 40. Of course, Nigeria, NEPA, all of that, the infrastructure, the funds to have refrigeration is probably not going to be feasible. But there's good news. Either the AstraZeneca or the Johnson & Johnson can be stored at much higher temperatures. So the hope is that when those are, start coming out a little bit more, that hopefully they're affordable, or not even just affordable, hopefully they're nonprofit organizations that will hopefully pay for those types of vaccines to be sent to Africa, where there might be issues with refrigeration. So again, there are options coming down the pike already here, and that's the AstraZeneca and the Johnson & Johnson that require higher temperatures for storage. I don't know what the degrees is though, specifically, if anyone knows how many degrees.
2 to 8 degrees.
For the AstraZeneca or for the
AstraZeneca. Right. And I also believe the Johnson & Johnson, it's much higher, so that's really good. Right. I mean, if we're having trouble finding freezers, I can't imagine. Yeah.
Yeah. In addition, the Johnson & Johnson vaccine is a single dose vaccine.
Right.
that will be easier than, you know, having to have a 2-dose vaccine where tracking down people might be difficult, you know, or challenging in Nigeria. The one thing that gives me hope is Nigeria and basically the developing world has been set up for mass vaccination campaigns where possible. And I remember as a kid, you know, lining up to get like the meningitis shots every summer or every 2 summers. So, which is what, you know, the United States is looking at doing, setting up mass vaccination sites or like vaccination tents. The WHO working in sub-Saharan Africa, developing countries, already has that framework. So getting the vaccines will be the, you know, the challenge, but then this getting the vaccines into arms will be much easier than what we're seeing in the United States. So that's a you know, a bright spot that I see, you know, with regards to Nigeria getting vaccines. So.
No, Iliya, it's always very good to see the bright spots, and you know, just to buttress what you're saying, there's already sort of an infrastructure for vaccination in Nigeria. But you know, a growing challenge specifically to COVID-19 is the plethora of conspiracy theories, and some of them are perpetuated from figures that are really respected, you know, like church leaders, you know, community leaders. Don't you think that you know, that might lead to sort of increased vaccine hesitancy? For example, even within you know, family members, you know, I've had to like really sit down to let them know that no, it's going to be fine, you know. So there's, you know, what do you think about just the whole information that has sort of led to this, you know, God forbid me take the vaccine, you know, Bill Gates and all, poor Bill Gates. Yeah. So what's your take on that?
I think it will take some work. I would like to believe that for every, you know, influential figure that we have, whether it's, you know, a clergyman or a, you know, a government official, there's also, you can also find someone who will be a vaccine champion. So for every influential person, you can also find someone on the, you know, who can influence people, you know, to get vaccinated. I like to think back to, you know, times back when we had myths about the Y2K bug, when we had myths about, you know, several other things in the past, and they didn't really pan out as feared. So as people begin to take vaccines, you know, anecdotal information is going to be very vital. You know, you see your family members or your close friends getting vaccinated and doing all right. I think over time, those fears will begin to dissipate. It's not going to be an easy task. It's going to be an uphill climb. But having, you know, having elected officials, you know, sports athletes, you know, people who occupy a sphere of influence, getting the vaccine. So identifying those advocates and, you know, helping to propagate the message, I think gradually people will come on board.
If I may just add something, I think we have to challenge each and everybody who is on this forum, you know, with great questions that are being asked. And I think that's the essence of a forum like this. You know, each and everybody who has been in this forum really should not just sit down with the information they've gotten, you know. I mean, if you go out there and I mean, even if it's one person you're able to explain to as to more information you got regarding this presentation, you know, I think our work is done. You know, I think the main issue really is taking time to explain in whatever way you can as to how this vaccine works. I think that's really the main issue. There's a lot of conspiracy theories as to how it works and so on. You know, but if you're able to at least help to explain more and say, well, without the way it works, it certainly does not change it doesn't alter your gene. Pregnant women being also concerned as to whether pregnancy should prevent them from, for people who are pregnant, should they not take the vaccinations? You know, and studies were not done with pregnant women, you know, but with the CDC, you know, and what they say, they're recommending that even people who are pregnant, you know, they think them availing themselves of the opportunity to have these vaccinations, eventually once it gets to their turn, they think it goes a long way in helping, to at least boost their immunity. In this country, the rollout of the vaccine is in stages, as much as we're talking about our country, Nigeria, being able to hopefully liaise with companies, that have vaccines that can be stored close to room temperature is one. I certainly will hope that the government really will be able to also have like a staged rollout of vaccination. I mean, it's easy to say that in theory, but we know where our country is one in which, once you have the means, you jump the line, and you get the vaccinations prior to people who are on the first line, healthcare workers. And it really saddens me, to hear, in addition to the general population, as to more so healthcare workers who are the first line, trying to at least treat people in the hospital being infected, whereas all other people who are not in direct contact, with people, except of course maybe in the community, they're probably going ahead to receive the vaccinations. I certainly hope that will go a long way also. Thank you.
So just to add to that, I'm just going to share a little personal experience.
Okay.
So my mother lives, she's here with me, and I and my wife are actually healthcare workers as well. I got sick, I think the 15th of December with COVID, and it was a horrible experience. And she's seen me like really sick. I had everything that you could think of with COVID symptoms except the shortness of breath. So I was losing weight by the minute. I wasn't eating. I wasn't, just sleeping. And before she came, or before I got sick, she didn't want to take the vaccine. And she was always saying, "No, I'm not going to take the vaccine. I don't think this is actually true." And the false belief from what she's heard and what people are saying regarding the COVID and the vaccine. So when she see me being sick, really, really sick, and my wife as a healthcare worker got the vaccine as well, so she wasn't sick, prompted her to decide to take the vaccine. So I think I believe in this forum there's been one person that's been sick or know someone that has been really, really sick, and you see that family member or you see yourself being sick, I don't think you should be hesitant to take the vaccine. So if it means, if I had taken the vaccine, I don't think I would go through that phase of the symptoms that I went through, and it was horrible. It was very horrible for me. I thought I was going to die. Even my wife keeps saying that she thought I was going to die from the way she saw me for the 2 weeks I was laying down in bed. So it's just education, letting people know the awareness, letting them know that vaccine do save, and it's better than nothing. It's better than you having the vaccine than you getting sick, because you never know. The good thing, and another thing on my part, like Dr. Iyamu said, is comorbidities, hypertension in in the Black community, obesity in the Black community, cardiac disease in the Black community. Those also add to you being really sick when you get the COVID virus. So if it's just creating awareness and educating people on the vaccine really do work, and yes, it is, because at the end of the day, I'm home and my wife got the vaccine and she didn't get no symptoms at all from taking care of me when I was sick. So just to add to that on a personal note.
And I would like to piggyback on Dr. Iyamu's comment about pregnant women. So during the trials, women were advised not to get pregnant. Some of them did, and they had no adverse outcomes. So at this point, the American College of Obstetrics and Gynecology has put out a position paper recommending that pregnant women still get the vaccine. And Dr. Cyril, we're glad you're okay.
Thank you.
And we have some interesting questions, just relating to the COVID-19 illness itself. And I think this one is quite important from Ogakola Rashid. So he's asking, what are the long-term effects? Like if someone gets COVID that person is well, what are you seeing? Dr. Ronke, you examine, you see some of these things, on the micro level. What are you seeing? What are the long term? I mean, the pandemic started, over a year ago, so we still need more time for more data. But at least now we are seeing some things that I think should be cause for concern. So I'd like you to address those.
So on when you talk about the pathology of the disease, really what it does is cause blood clots. And so these blood clots affect the lungs, they affect the heart. You can have them affecting the brain, which is where people present with confusion because basically they're getting infarcts in their brain. We've seen this in the skin. We've seen this in the reproductive organs. And so it is a multi-systemic disease. It affects the whole body. What we are seeing, and I will defer to my PM&R colleague on the panel, are the fact that even when people have supposedly recovered from the disease and their tests, their PCR tests are negative, they're no longer shedding the virus, they still have long-term clinical effects, excessive tiredness, some of them who were previously healthy. And so it's really not just people who had underlying conditions, but people who were previously healthy have long-term side effects that I think my clinical colleague, PM&R, can address.
I can add to that, absolutely. So I see patients who, after they've been infected and either a short hospital stay or a long hospital stay in ICU, they come to see me in a rehab hospital. But I also have outpatients who are patients, patients who didn't go to the hospital who had COVID. So I'm going to start with the ones who didn't go to the hospital, kind of like our brother here, Dr. Cyril, who had really bad COVID, stayed home, managed, and we're fine. What we're finding is that a lot of them have all of these vague symptoms that linger. One of them is smell and taste. I mean, there are patients who 6-7 months down the line, and even 10 months, because we've been dealing with this for about a year, are still saying that their senses of taste and smell have not returned. So that's kind of something that you can manage. Then there are other people who just overall just have this ongoing fatigue that just never seems to go away completely. Their energy levels are not as good as they were before COVID, right? There are issues with the nervous system, and this is patients who didn't go to the hospital complain of tingling and numbness in their fingers and in their toes. So again, these are, and there's just a plethora of things that patients are complaining about, and definitely tied to COVID, because I didn't have these symptoms. I had COVID and these symptoms have lingered and they're not going away. Doc, when are they going away? And the answer is always, I don't know. We haven't dealt with this before. We don't know if these things will go away eventually. And whether or not a lot of these symptoms are not necessarily treatable. Like if someone has fatigue, you kind of manage that, but the hope is that your body will find ways to just kind of recover and reset. Now, on the hospital side of things, and this is just always really sad to see, is when patients get COVID, like Dr. Ronke said, it affects their brain, it affects their muscles, their nervous system. So in rehab, we see these patients who had COVID who come in like a traumatic brain injury patient. Can't talk, can't communicate. We're teaching them how to communicate again, how to talk again, how to feed again. And even when we get to the end of rehab, they're just not the same person they were, meaning that you can tell that, I don't know if you've seen somebody who's had a bad car accident and a year later, they're just not the same. This is what you're seeing with these patients is, even after all the rehab, they're just cognition, meaning that, their intellect, their conversations, their higher thinking, reasoning, and all that is just a compromise. And the thing is, will these things go away or not? The answer is there's no telling. However, I would say that if someone has COVID and the blood supply to their brain caused enough brain damage, more than likely that's how they're going to be for the rest of their lives. So I've done a little self-survey, right? And so when I have patients in rehab who have these really bad side effects or complications, it's their family members. And I live in the South Atlanta, where there are a lot of people who believe in this conspiracies and COVID is political, don't wear a mask and all that. But I asked them, I said, well, would you get the vaccine? And every one of them says, the family members or the patient, and if this had not happened to me, I would have said no. After this experience, the family members and the patient, every one of them says, absolutely yes, it's a no-brainer, they would get the vaccine. So I don't know if I veered off the question, but the question was about the long-term effects, right?
Yes, yeah.
Right. So the long-term effects, we don't know how to treat all of them. It's really just a wait and see approach, manage the symptoms, and again, just wait and see.
And so after that, sorry, Kingsley. So we also know that COVID, disproportionately affects the lungs. So it's something it's a pneumonia still, for the most part, even though it's multisystemic. So as a pulmonologist, we know that there are certain consequences that are irreversible. So once someone develops fibrosis, which is scarring of the lungs, there's no coming out of it. The best you can do is to do some rehab, try to help them find ways to cope with a new baseline or a new level of function. So in my clinic, I see patients who were previously healthy, did a lot of manual labor with no limitations, and then they have fibrosis, they're on oxygen, they can't go back to work, so that we know is irreversible. COVID can also affect the heart. So we have an entity called COVID heart. Sometimes the electrical conduction of their heart, or how their heart beats, the rhythm of the heart gets distorted. They might need pacemakers. So, and again, those things, in most cases, there's no coming back. It's kind of the new reality. So it's really a big deal.
Thank you for sharing. Dr. Anna, have you seen like COVID-induced like diabetes? Because that's another thing that's reported.
I haven't seen that, actually. That's something I haven't seen. There are patients who have borderline, what I've seen is patients who've had like a borderline diet-controlled kind of diabetes. And then after they leave the ICU or medicine, they come to us and they now have to be placed on diabetic medication. But I've also seen that in non-COVID patients. So again, whether it's COVID related or not, I don't know the answer to that question, but I haven't personally.
So go ahead.
So that's my answer.
There was a paper put out, I believe, in the fall of last year. So there has been an increase in type 1 diabetes that is insulin dependent initially in young adults. And for me, this is not even, it's personal to me because one of my friends, her children did have COVID back in the summer of last year, and one of them did develop diabetes. So she's currently on insulin at this point. It's a post-viral syndrome, attacked her pancreas, and now she's insulin dependent. But there have been multiple cases, so it's not even at this point just case studies, and they're seen in young adults. There's also the issue of a syndrome in younger children who I think we're seeing a lot more of that in the second surge, with children being admitted with very bad viral pneumonias and other issues. So again, it affects all generations. It's just that the outcome in younger children has been better.
On a personal basis, I'm in the hospital. Certainly, I've experience of having seen patients with COVID who had COVID, came in with a stroke or a blood clot in their lung. There was even a patient we saw had a large blood clot in the heart, in addition to the lungs. Of course, blood clots in the lower extremities are also possible. With in addition to what Dr. Iliya said, when you have a lot of scar tissue in the lungs, several of the patients who are living in the hospital, they still have a lot of the need for oxygen, supplemental oxygen, to the point where you have to arrange oxygen for them to go with. And it's only time that really is able to tell us to how long the lungs do improve to the point where they do not need oxygen again, just on the personal level, coincidentally, Gold may call me, informing me that he wanted me to be part of the panel here. I just had the second shot of the vaccination, So in terms of side effects, I think with most of the colleagues that we have seen, other than just like just as if you're having more just like a low-grade viral illness, just generalized weakness, pain in the muscles, pain in the joints, and some people have fever. There were a few who had to maybe stay about a day or two at home just to kind of recover from that. I did not have to lose. I didn't have to skip work as a result of taking the vaccination. Of course, I took Tylenol and Motrin. In terms of the side effects that I had, again, maybe slightly more than I probably would say I had when I get the usual flu shot, but then it wasn't really life-changing. I still check every day. I haven't developed any extra leg or a tail, just to kind of piggyback onto the question that the colleague asked. But certainly only time will tell. In terms of the sugar, I have a patient who came in. Obviously, when patients have COVID, part of the medications, especially when they have severe COVID, when their oxygen levels are low and they have lung disease, they have to be put on steroids, what they call dexamethasone. During the period where they are on the steroids, obviously their sugars are going to be high, for the most part, when ultimately they get off the steroids, you want to expect the blood sugars to go down. Coincidentally, I have a patient who came in about 2 years back. I mean, he was not diabetic, he had COVID about 3 or 4 weeks ago. But for some reason, he had, because his lung function did not really improve as fast as one would have expected. He was still on steroids, but then even the test, what they call A1C test, was above the level that you would just ascribe the blood sugar levels being due to him being on steroids. As to whether this is coincidental or as a result of the COVID, I think the jury is still out on that. Thank you.
Thank you so much. So we're honored to have the secretary to the Delta State government here. He's 81 set, same set with Oga K. And it's very late in Nigeria, so I'd like him to I'd like the moderator to unmute him so that he can talk about like the Delta State government response. I think it's be good for us to hear from someone that is sort of like in the thick of it in terms of making policies regarding COVID-19 vaccines at state level in Nigeria. So I'll call on Oga Ebie to comment on the Delta government's efforts on this. Is he on the call?
Yeah, he's on mute.
Okay.
Can you hear me now?
Yes, yes, sir.
Okay, hi, hello everybody. Hi, and thanks a lot for this. I mean, I joined a bit late, but I've learned a couple of things. Sorry, before I go into what we're trying to do here in Delta State, and in fact, coincidentally, we had a 3-hour Zoom meeting earlier on, which was chaired by the governor and essentially with the health team. I have a question. Lately there's this drug, ivermectin, which has been making a lot of waves in terms of a prophylaxis and also as a treatment, part of the treatment protocol. Funnily, in Nigeria, Nigeria is an interesting country. I mean, this is a drug that was initially, I think, used as an antiparasitic drug, right? And then used for river blindness. Towards the end of last year, it was retailing at maybe 8,000 naira for a pack of 500. Now it's over 50,000. So it's, but then, there are a lot of questions, and I know that a lot of studies have been done, or a few studies. But what do you guys think about the drug on its own? Because there's a lot of talk about it. So I just thought, at this festival to get some information from you guys on that.
So is anyone in the panel familiar with the trials on ivermectin against COVID-19? So ivermectin, for the rest of the audience, so ivermectin is a drug that is used for parasitic disease called schistosomiasis. And so it's being tried right now for therapeutics for COVID-19. And I don't know what the numbers, what the data is, but is anyone familiar with, on the panel, is anyone familiar with trials with COVID-19?
So for outpatient treatment with COVID-19, regarding ivermectin, there haven't been any trial based on the CDC guideline or the based from up-to-date to medicine. So there's where we go to get our up-to-date information. There haven't been any trials on with that drug. What drugs that they do use for outpatient settings are mainly what we call the monoclonal antibodies drugs. So those are what they do give to patients on an outpatient settings. And also you could give the steroids, but mostly steroids are actually given IV. So, but for the ivermectin, I haven't seen any trial literature about giving ivermectin to improve patient health, and that's all I could say for now. But we could look into it to see if there's any literature. I don't know if Vladi, from the FDA standpoint, is there any trial with the ivermectin drug?
So of course, I'm here, just giving my personal professional opinion and not representing the FDA. But again, having said that, I'm not aware that, that we are reviewing any trials regarding ivermectin. However, I know there have been a few. Most of the data that generated the excitement were all from retrospective, trials. Basically, they were looking back at patients who had been treated with ivermectin just based on hospital records, and it had appeared that there was some signal there. So, but then more recently, over the last couple of months, there have been a few small trials, most of them in Asia, Bangladesh, Pakistan, that have studied 50, 60 patients in what we call randomized trials. They basically assign patients, to either ivermectin. Most of them have been ivermectin in combination with a few other drugs, doxycycline, azithromycin, or to placebo. That's nothing. So the challenge that in some of those trials, they've looked at various endpoints. Some of them have just looked at the clearance of the virus, in the first week, second week, how much does it drop, the levels of the virus, and it appears, to be effective. A few of them have looked at hospital stay in patients who are hospitalized, and again, it appears there's some signal. But some of the challenge, these are very small trials, so whatever we see, we don't really know whether these are going to stand up to scrutiny if you really conduct them in larger trials. Then secondly, is that it's in combination with other drugs. So we don't really know what ivermectin is adding to the combination. Is it doxycycline? Is it these other agents? We just don't know. So, and then again, these are also different populations. It may be a little different, what you'll see in Africa may be a little different. And again, it all just speaks to the small size of the trials, such that we can't be confident of whatever effect, whatever treatment effect we see in these very small trials. Now, that's all science, right? Now, based on the little we know, if I have someone who I think, if they call me today, that someone, tested positive for COVID today in Nigeria, I will ask them to give that person just based on the data we have, because this is not really a toxic drug. There's very little, by way of side effects. And if there's some signal that it may help, reduce progression to disease, based on what we know now, just on a personal level, I will ask them to give that person. But that's not based on science. That's just based on, what we have now.
Well, Ogaibi, just to add, I think this also presents an opportunity, I think, for Delta State government to call, the leaders of the COVID-19 committee and and think about just designing a randomized control trial to see what ivermectin does in the Nigerian population. Because just like we are learning this data from Bangladesh and other places that is tried, you know, the world can also learn from what data is coming out from Africa. So just a suggestion, since you're in the thick of it.
And let me
I'll pass the mic back to you to talk about like what the state government is doing.
Okay, well, you know, the problem we have in Nigeria is on the one hand, you know, I tend to say a bit of ignorance, then we have the conspiracy theories, and then we just have the conscious unbelievers who believe that, you know, COVID is, as they would say, it's not my portion. And then you're wondering, you're asking them, whose portion is it? So a lot of the populace think that it affects those that are in the bit of the elites, you know, those that, according to them, travel abroad, those that stay more in air-conditioned rooms. So we're having a lot of problems in that regard. Coming from the first wave to the second wave, I mean, for us in Delta State, and this was, you know, my from the meeting earlier today, we were very bullish in the first wave, did everything that we could possibly do to try as much as possible to do sufficient testing, contact tracing, and then the management as well. But coming into the second wave, of course, because it looked like the numbers went down, to an extent, it seems like we took our eyes off the ball, and that was really the thrust of today's meeting. You know, I think for the state, based on the meetings they have, you know, at the federal level, each state is meant to test. I think they've increased it now to 2% of your population. So, for example, if Delta State has a population of between 4 and 5 million, it's expected that we will test 2% of that, and we're really way below that. Now, for the vaccine, I think in the first phase, I think Nigeria is meant to get 100,000 or something like that, which is really will really go nowhere. And so when you break it down to the number of states, you're probably getting just a couple of thousands. And in terms of the rollout, the first set of people that, and this was based on what the Commissioner for Health presented today, is that the frontline workers, that's the medical workers, will be top on the list. Then after that, you go to the, I think the over 60s, and then it comes and cascades down. Because, for instance, in one of the hospitals here in Asaba, a lot of the doctors or a lot of the medical workers, they got infected. Because what happens is that a lot of people present symptoms of malaria. And so people just, tend to treat. And then people also don't really like to submit themselves for testing. Even when they go for testing, they put wrong or false information. So you actually can't even get them, to call them back to give them. You call the numbers and the numbers are wrong numbers and so on, because of stigmatization as well. Even for those of us that are educated and are considered to be up the ladder, you find that a lot of people just don't want to get tested. And so it's a bit of a problem for us. But, we're also looking at the storage facilities in terms of how we can do that. Now, fortunately for us, we've dealt with things like yellow fever, and we've done quite a bit of vaccination programs. So we have some of the facilities, but I do know that we're trying to make sure that we have the right storage facilities. But another thing that we're also working on today, and I know I had to make some calls, is in terms of the mobile storage. So when it comes into the state and we store it in the cold room, how are we going to get it from there to the communities and to the localities? And so the governor did say to the commissioner that he needs to move very quickly to try and see how we can get the mobile storage facilities. And just this evening, talking to someone, we were thinking of how we could get what's it called now, the ultra low freezers, but I don't think we have that in Nigeria. And so he was trying to explain to us that if you don't, the ultra low freezers are probably not available in Nigeria. And even if they're available in Nigeria, because of our roads and everything, something can just go wrong. And so you may be able to store, I think, say for instance, the Pfizer vaccine, you may be able to, when you take them out of your storage facility, which will be ultra low, you should be able to keep it for another maybe 5 days or so in normal storage. I don't know if that's correct. I'm not, So those are some of the challenges that we're having in terms of vaccine. First things first is that we're probably not going to get enough. Even when you get it, then you then have to think of storage, and then because of power issues as well. But another thing for us, we already have a solar walk-in cold room, which has been in place. And so that should help us in terms of attaining a temperature of, I think, between 2 to 8 degrees Celsius. For the ultra low freezers, I can't say for certain if that's in place, but the biggest one is going to be the refrigerated trucks, where because you're really going to have to take them around the state. And anywhere you're going is probably max 2-3 hours, but then you have to think of if something happens on the road, whether it's in the riverine communities. But it's then another big issue that we have, also there's also been the apathy of the health workers as well in recent times also. They just seem to have a very lackadaisic approach or attitude. But one thing we did was we made sure that we provided them with extra incentive, and this was during the first wave. Extra incentive in terms of allowances, health insurance, and so on. Unfortunately for us, last year we lost 2 doctors, to COVID who contracted it in the line of duty. But at least we're able to prove that with the things we put in place, at least there were enough welfare packages for them because there was insurance. And just today, the lady in charge actually confirmed that the insurance had been paid to their families. But now, then the next thing also we've centered on is in terms of information dissemination. How do you get it out there to the public? Because we have big problems. The basic protocols of keeping your distance, wearing the mask, avoiding large gatherings, we just don't adhere to it. And of course, whether it's from the churches to the traditional institutions or to just people in general, it's a big problem. And so I think from next week, I'm going to be convening meetings with the Christian Association, with the traditional institutions, so that we can continue to enlighten them. Yeah. We just need to, continue to enlighten them. I had COVID last year, and just like Dr. Cyril said, I had everything except for respiratory issues. So I know what I went through, and a lot of people don't believe in science. They just don't believe in it, and so it's taken a lot to try and get people to understand this thing. Now, sadly for us also, we had a couple of high-profile deaths, and I always used to say to a lot of people around here that we're not going to take this seriously until it hits close to home. So when you know someone that has that went through a very tough time, or someone that unfortunately passes away, then that's when you begin to take it seriously. If not, it just remains a statistic, and where they say, 5 people died. I don't know who the 5 people are, but in recent times, we've had a couple of people who have, passed away. So, everyone's now like, oh, wow, you mean COVID really kills, and so on. So there's a lot of work for us to do, a lot of work in terms of sensitization, orientation, and just making them know that this second wave and the variant of this second wave seems deadlier than the first wave, and that, you know, but are we doing as much as we should? The answer is definitely no. That's the truth. That's the truth. It's just sad, you know. But we'll keep our fingers crossed and do what we need to do. Thank you.
Yeah, thank you so much. Thank you so much, Ogachi.
Oh yeah, sorry. And one last thing also is oxygen as well. You know, oxygen has become a big issue here in Nigeria. So I know at the national level also, the state governments, and also working with the federal government, the state governments are giving matching orders to make sure that they establish oxygen plants. In Delta State, we have 6 oxygen plants, but of course, as you know, the capacity is not. I mean, each of them probably does between 60 to 75 big bottles of oxygen per day. But the demand has shot up it's so high now that really is the biggest problem in terms of oxygen. Yeah.
Yeah, thank you so much, sir. You know, I know that when someone in government is saying things they are doing, some people will say, oh, you know, he can only say the good things, but you know, kudos to all your team and their efforts in tackling this challenge. One thing I know, and I'm not saying this to pander, but one thing I know is that Delta State is actually one of the leading states when it comes to healthcare. You know, the governor there is a doctor. When it comes to state health insurance, you know, they've really gone far. And, you know, the truth is that there are limited resources, but it looks like even with those limited resources, you know, we're very proud to have you in government, sir. And please keep up the great work. I know it's very challenging. One thing, I don't know if you were on the call before when we talked about like just the logistics of vaccines in Nigeria. And, you know, the panelists and, you know, we as a whole, we sort of suggested that vaccines that are more viable in higher temperatures would be best for Nigeria. So things like the AstraZeneca vaccine. And India, I don't know if you guys know this, but India also developed their own vaccine. It went through clinical trials, it's 91% efficacious. They approved it there and it's way cheaper than most of the big pharma companies. So those are some people that, you know, it's possible to start talking to in terms of like seeing how those vaccines can be gotten in Nigeria. And one major problem India is having is that they have so much vaccines, but few people want to take it. So they have a different problem, you know. So those are just some ideas in terms of when you're talking with the COVID-19 team, with the governor, you know, some ways that it could work. You know, yeah, and you know, thank you again very much for just your insights. We have a lot of questions, and I know our time is definitely fast spent, but I will just try and take a few more, and then I can just open up. You know, the moderator can just open up the video and people can chat and also ask questions like verbally. But you know, we've had questions about like would kids be able to get the vaccine? And, you know, I think Dr. Ronke answered that question in the chat. There's now trials for, you know, for kids and looking at what the numbers are for kids. And I'd like to make a correction. You know, I had earlier said that, you know, Chedo was 81 sets with with Oga K, and, you know, I don't want to buy job because there are lots of lots of my seniors here. They are not the same sets. So Oga K came into FMS, you know, year 3, and he came into FMS year 2. So you just to make that correction so that I don't buy job. But yeah, I think we have sort of expanded a lot of the questions here. I think one question that someone is asking is how can we boost our immune system? You know, if you've not gotten COVID-19, how can you sort of stay immune ready if you have not gotten the vaccine? Are there things to take? Are there certain vitamins? One thing I'll add is if you've not gotten the vaccine, a mask is over 80% efficacious in protecting you from the the virus. So that's another vaccine, you can use, vaccine in quotes. But yeah, I'll just open it up to the floor. Are there things that people can take, to keep strong immune-wise?
Well, I can talk a bit about that. So your immune system is the things that contribute to your immune system. There are multiple things. Let me put it that way, right? So, you can have like a 91-year-old that smoked all of their lives and doesn't have a single disease because just genetically, their bodies just have really good and strong immune system. So genetics is very important, right? So I'll start by saying, hopefully you have good genetics and that your immune system, is already healthy genetically now. So that's one aspect. Now, as far as what can be done, I talked to a lot of my doctor colleagues about all of the different suggestions for vitamins and for, lemon juice and ginger and all that. And I have some doctor friends who say those things don't work, right? But then, there are people who swear by certain foods that will help boost your immune system. Hey, the thing is this, if you're eating things that have nutrition, there's something about nutrition that helps to repair or maybe possibly boost your immune system. So it doesn't hurt to eat things that are green. And then there's something called cruciferous vegetables like cabbage and broccoli that they have a certain ingredient in them that they think might help to either boost immunity, or if you're in contact with the virus, it'll help to fight it before it causes any issues. I would say that personally, I tried something, and I don't know whether this was boosted my immune system or not. I haven't had COVID this whole time, thank God. But I did have a period where I had symptoms of just like a runny nose and all that. I was COVID negative, but I was like, oh, what if I'm falsely negative, right? So I went ahead and did what I have kind of not ridiculed, but have thought, that doesn't work. I went ahead and did like a little concoction of like a ginger and lemon and all of that for myself. I said, look, I'm going to try anything. And I feel like the cold symptoms that I had within a day or two disappeared. Whether or not it was my mix of ginger, lemon, cayenne pepper, which is Nigerian pepper, just put in, and I mix it all in the drink. Whether that was what either boosted my immune system or stopped me from developing whatever was brewing, I don't know. But again, it never hurts. Healthy eating, nutritious eating never hurts. And then you also pray and say, God, I pray that I was born with just a very healthy immune system, genetically. That's all I have to say about that.
Great. So, our time is fast spent, and I want to be very, respectful of everyone's time. There are two questions I'll take, and then I'll call on the president for closing remarks, and then we can leave the Zoom open for people to chat and ask questions informally. Well, one thing we're going to do is, if we didn't answer any question that you had sent through chat, the ESCO, they're going to take all the unanswered questions and have the panelists answer them, and it will be posted on the website. And this video too will be posted on, the recording for this will be posted on the website as well. So I think the first question is, what's the story about hydroxychloroquine? I don't want us to dwell so much on that question because I think it's something that, it was a huge controversy, but the standard for clinical trials and validating drugs have shown, which is what they call randomized control trials. They've done several huge studies that shows that there's no difference. The studies that showed that hydroxychloroquine had like some effect, they were smaller studies and they were non-randomized. So the best quality trial to put a stamp on anything is a randomized control trial, and those didn't show any difference. And there's one question from Jide Dada, Oga Jide Dada, and he's asking, what does the non-detected mean and in a PCR lab report? So I'll just throw it open to anyone that want to take that. And then I'll call on Kayode to give closing remarks.
So I can take the question with the PCR report. So basically, if it's non-detected, it means that you do not have COVID-19. So we target 2 sites on the virus, and either it's detected or non-detected. The FDA provided guidelines and said we can't call it positive or negative because sometimes people detect one target and not both. So basically, if it says it's non-detected, it means it's negative.
Thank you. Let me see if I can squeeze in one more question. Someone, I can't remember, but I know I kind of skimmed through it in the chat. But someone was asking, why are we so focused on vaccines and not therapeutics? I think that's a summary of the question. That's not the question, because there are so many chats now, but I know I read that. So why are we not focused on therapeutics as much as we are focused on the vaccines? And another question, I think this will be the last one, is are we going to be taking the vaccines every year? And I think Dr. Amaza answered that, like, we don't know yet. We're still looking. So why do you think I think the right question is, are we so focused on vaccines and not therapeutics, or are we focused on both in a comparable manner?
If I may take that, I think it's a comprehensive approach, really. Prevention, one, then of course, patients or people who get infected, then you're now talking about therapeutics. I think the guidance for this talk was more of just dwelling on the vaccination. I think that's why most of the discussion has surrounded the issue of vaccination. But certainly therapeutics for patients who get ill, either being treated at the outpatient setting or in the hospital, yes, that's certainly another large field to talk about. I think overall, irrespective of what we're talking about, prevention, treatment, and so on, I think the key, even for people who have access to the vaccination, the emphasis still has to be laid, irrespective of whether you've gotten the vaccination or not. The fundamentals to preventing and acquiring the COVID disease, universal wearing of mask or face covering, maintaining a safe distance, at least 6 feet, avoiding crowds and congregate settings. Indoors versus outdoors, outdoor settings are certainly preferable, and frequent washing of your hands. A pound of, whatever the amount of efforts you channel towards prevention goes a long way, in this disease. Thank you.
Thank you, sir. So I think I'll just sort of try I'll just attempt an impossible task to summarize this 2+ hour meeting. So I think before I call on the president for his closing remarks. So number one, the vaccines are safe. Safety is very, very important. 2, the process on which the vaccine was approved was very thorough, and safety was the number 1 consideration, and efficacy or effectiveness at all-time high, 95%. The other thing we learned is that you would get some side effects, most likely, if you get the vaccines, but these are not side effects that would kill you. These are things like nausea, maybe slight fever, but these are not things that would that is adverse enough for you to worry. Number 3 is COVID-19 is definitely something we don't want to get, and a number of people in this call have gotten it. And we unfortunately lost, classmates today, which we observed a 1-minute silence in honor of him. And so it's definitely better to get the vaccine if you have access to it, or at least wear your mask and do all those things to prevent COVID-19 from happening, than getting it and hoping that you go through it, alive. It's not a pleasant experience. So the vaccines are safe. Number 4, which is on a side humorous note, is that you won't grow horns. It's not 666. Nobody is going to type you or implant a chip on you when you take the vaccines. Number 5 is that Nigeria has a window of opportunity to get some of the newer approved vaccines like Johnson & Johnson, AstraZeneca, the AstraZeneca vaccine, and some other vaccines that are not necessarily Western country based, like India, that would allow the current infrastructure to keep the vaccines viable. Number 6, I think all of you have been fun, and thank you so much for being on this panel and answering all the questions. Like I said, there are going to be answers to other questions that were not answered in this panel. And thank you everyone for joining, especially those in Nigeria, because I know it's quite late right now. So I'll call on Ogake to give his closing remarks, and then I think the Zoom call will be open for just chit chat or informal questions to the panelists if they're still going to be here, and just some sort of to unwind. So I'll call on Ogake for the closing remarks.
All right, thank you so much. Thank you so much, Kingsley, for this amazing job. As you can see, we have probably the highest number. No, I think when we had the male plumbing, we had more people join actually.
Y'all are so predictable.
Yeah. Male plumbing actually brought in about 75 plus. Today we had as high as 55 plus. So it still carries the day at any point in time. But this was amazing, and I hope that I see a whole bunch of questions that have not been answered. So what we plan to do is take these questions, send them to the group, the doctors, and then maybe have them answered, and then paste them on our site so that everybody has at least an answer to their questions, because it's really important that we have the right information so that we can spread it out and help save lives, really. Because that's what will happen. You convince somebody, they take that vaccine, and then they are alive because they listen to what you told them to do. So I want to thank everybody that actually came on. I just saw Oga Chiedu. First of all, Oga Chiedu is my Oga. He's 81 set, I'm 82 set. This is how you go and set me up. They will now be frog jumping your president after this meeting. Oga Chiedu is my Oga. Then he has Oga that is 80 set. For those who are asking, Oga K get Oga. I get Oga Chiedu is my Oga. Oga Kenneth is my Oga. Then them too, they get Oga 80 set. Then 80 set, they get half 79. I'll tell you that story later. But anyway, for those who want to know. So thank you very much for everybody that came. We're going to try and get your questions answered. And, for those who basically, prepared so much to be able to deliver this, our heart basically goes out, and we're just very grateful. We're very grateful for all the ex-jam and ex-job, particularly grateful to Dr. Ronke, who actually we just pulled and said, look, you have this information, come and give it to us. So we're very, very grateful on behalf of the ex-jam of North America. And then the whole ex-jam generally, we say thank you for what you have done, including, so the problem with my ex-job, everybody knows I love the ex-job. If I don't mention them in particular now, they'll come and pick me later. Okay, so you do not remember. So a big thank you to the ex-jaw of North America and the ex-jaw worldwide for, basically being a part of this. And let me say it again, you always make our meetings very colorful. You bring a lot of insight, and we really appreciate the intellect that you always bring on board. Oh, by the way, that high-rated number of the male plumbing was delivered by an ex-jaw urologist, just so you have the complete picture. All right, so I think I've covered all the ground. I will not be in trouble with anybody. So thank you very much.